25 years of experience in different levels of pediatrics and neonatology in different countries. She's affiliated with Cochrane Collaboration and have authored many systematic reviews. And she is affiliated with a grade for assessment of evidence and have designed innovative knowledge dissemination tools. She is also a member of committee for pediatric focus, which she will explain to us now. What is it? And she's editor with assessment module and peer reviewer in the journal. She's mentor of to focus learners and pediatricians. We are welcoming her for her lecture today.
Thank you for the introduction, Doctor. Thank you for the organizing committee of Breathe Well for giving me this opportunity. Let me get started with my presentation. My topic today is lung ultrasound in pediatrics. Lung ultrasound in pediatrics. Although I recognize the audience is multidisciplinary and I promise that whatever I talk is applicable to adults as well, although some special applications I will dedicate to pediatrics. Lung ultrasound in pediatrics is my topic. I will dedicate some time for the overview of what is lung ultrasound and proceed with what's the current recommendations, future potential, and our interesting journey of institutional experience. Declaration before I proceed. I'm one of the editors of Focus Atlas Junior, and I have used some of the clippings from Focus Atlas for this presentation. And I have contributed to the development of examination module from the Focus Academy. And of course, I am an advocate of focus, so I might be naturally biased towards focus in this presentation, although I quote ample evidence wherever I talk. Objectives: I'll introduce lung ultrasound, and as I said, I'll dwell upon this for a good amount of time before proceeding to the applications in pediatric emergencies, applicable to adult emergencies as well, neonatology, and in specific situations where we can distinguish etiologies of pneumonia, wheeze, bronchiolitis. The audience who are caring for infants of this category would know the utility if we can distinguish between the two, and such similar scenarios. And as many speakers ahead of me spoke about, lung is not an isolated organ, and then to respect it in the continuum of cardiopulmonary assessment will be also one part of what I will be discussing. And of course, it is not an isolated imaging module. You have to integrate it with clinical information and biochemical information, and how the comprehensive picture assists in decision making will be the last part of my talk. So why lung ultrasound? We have many imaging modalities, and we have conventional radiography which assists us in our evaluation, but why lung ultrasound? So ultrasound, we all know, is a beam of sound rays which is interrogated as a reflection converted to visual images. This we know what ultrasound is. What's lung ultrasound? For a long, long time, it was known as lung is not very friendly with ultrasound for various reasons. Air is something which doesn't let ultrasound pass through, so it doesn't really cast an image. But over a period of time, and now it is standard of care in many scenarios, unlike how one of the previous speakers said it is not standard of care. It is because of its availability at the destination of interrogation. That is at the point of care. You and me as clinicians will be utilizing this, and will not be asking another technologist to be handling it for us. It's fast, it's radiation free. This is the salient feature of why lung ultrasound. What it is it's a portable device, of course, and it is repeatable. The fact that the speaker judged it to be something where it cannot be medico-legally plausible, for the fact that it cannot be the same as any other user preparing for lung ultrasound, but that's not the inter-user reliability, although it's a statistical term, is because of its repeatable nature, and it's feasible for unstable situations when you can't wheel the patient into a CT scan room or get a portable X-ray. You can do it yourself. This is the reason it is of importance in the recent times in scenarios like emergencies, ICUs, and it outperforms the other conventional radiography, the chest X-ray and CT scans. We will see about it in the coming slides. So it's ideal for situations like ICUs and emergencies, and the bottom line is it is considered as an extension of stethoscope. It's a visual stethoscope as it's called. So to give you a perspective, it's the bird's eye view, the conventional radiography. You get the whole picture. You get the whole picture of what the chest X-ray looks like and where is the localization of the pathology. But you can see the worm here in the bird's eye view. If you can imagine what is the worm looking at, you can see the worm's eye view. The worm's eye view is more proximal and more detailed, and that's what a lung ultrasound would be in an image-to-image viewing of the same scenario. So you will get more details and a wealth of information which will be used in decision making. So as I said, it fits into your pocket and it's an extension of stethoscope, and there are many blogs and information available across the board calling it a visual stethoscope, the new hospitalist friend. So I will be quoting evidences and good validated research publications with its citation and QR codes for you to have any further interest in reading. So I will quote two studies. This one, beyond diagnosis of pediatric pneumonia. So here it shows the cumulative evidence of what all other than pneumonia you can diagnose utilizing lung ultrasound. When I deal with the focus of what is ultrasound, I will talk about the other diagnosis. And the fact that it is radiation free and it's available at point of care, as I mentioned, would all be the salient features of what lung ultrasound is. And these are a couple of publications which emphasize this fact. So 10 years of pediatric lung was published in Frontiers Physiology. This emphasizes the fact that this particular science has been well studied, and publication, especially in neonatology, has already become standard of care because of its position in all the factors that I mentioned. And I'll show you some of the studies which has given its position as of the last decade. So what's the principle behind ultrasound or lung ultrasound? We use sound waves. We have a couple of probes which distinguish its utility. The high frequency probes for the superficial and the low frequency for evaluating the depth, and both are needed at relevant situations, specifically in adults. The disposition and the posturing would require the low frequency probes, and in high frequency, the details of the anterior lung fields can be interrogated. I will show you further what I'm talking until the nuts and bolts come up now. The A lines, B lines, these are the A, B, C, D, E of lung ultrasound. The A lines, B lines, and the C profile to put together gives you the whole gamut of what lung ultrasound is. So let's see what that would mean. This is a one-page view of how lung ultrasound is done. So as I said, this is a linear probe. It helps you get the superficial detailed pathology in the lung ultrasound, and this is a curvy linear probe which will be used to explore the lung bases. You can see how the zones are divided. The relevant color in the cross section tells you how the probes are placed, and it is divided into anterior, posterior, and axillary areas, and further superior and inferior, basically to get you the landmark. When you're reporting and revising the repeatability, you will need these landmarks. And what exactly do you do? So this is a scanning technique. You can see a linear probe placed on the chest. It is placed in an orientation where the probe marker would face the head end, and in one view, a clue In ultrasound, air, bone, stone, and serosa all appear white or hyperechoic, as it is said in sonographic terms. So if you see a hyperechoic area in the lung field, the first line that you would see is the pleural line. This is the tissue that you're trying to explore to make sense of what pathology is going on. So to help you locate the pleura, you have bones. As I said, the bones, the ribs will appear white, and also they cast a shadow. This is for you to localize the intercostal space. So two ribs in between intercostal space, and the first horizontal line that you see is the pleural line. What do you see? See the regularity, and also it's a highly reflective tissue, the serosa. What happens back and forth, the ultrasounds are pushed ahead, and that causes parallel horizontal lines. This is the bread and butter of ultrasound. This is A lines. These A lines mean aerated lung. In a normal, you need to know normal lung appearance in ultrasound to proceed to pathology, so I'm just going over those before I proceed next. So A lines, the parallel horizontal lines, normal pleuras, the smooth contour, and another property called the sliding with inspiration and expiration. The pleura slides over, the visceral pleura slides over the parietal pleura, that is seen as sliding, we will see further. And the lung bases with the curvilinear probe, you can see the orientation of the person, again cephalod orientation. We know what to see in the lung bases, infradiaphragmatic liver on one side, spleen on the other side, and supradiaphragmatic. This is where you explore, and in the normal scenario, what would we see? First, the A lines, you can see the lung sliding, that is the first parallel line, like ants crawling. This is normal. And if you see vertical artifacts, these are called B lines. I will come to it. This is pathologic, but less than 3 of these vertical artifacts are still physiologic. So the second thing I asked you to observe would be the parallel, the pleura with ants crawling kind of nature. This is the pleural sliding. When it's absent, there are lots of pathologies we can concur from it. We will go over that in the coming slides. So this is the lung bases. You have to see the aeration in the lung bases. As I said, it's a highly reflective surface. So when there is normal contour of pleura, when it reflects, you will see the subdiaphragmatic structures to be localized in the supradiaphragmatic space. This is called mirror image. If there is normal lung base, you will see the mirror image. And the next one, this is a beautiful lung base. What you will see is the costophrenic angle filled with aerated lung will go over the subdiaphragmatic portion. So this would be the curtain sign. So the curtain sign is the normal lung tissue going back and forth over the intradiaphragmatic structures, and this will say that this is normal lung. So what are the normal sonographic signatures? Presence of A lines, presence of mirror sign, and the curtain sign in the lung bases. These are normal. So let's go over what's pathologic. This is a one-page view of pathologic lung ultrasound, and this is all that one needs to know, and you can infer various patterns and all the lung pathologies you can deduce from this. So first one, if there is any fluid in the path A lines that we examine, it will get deflected and you will see the vertical artifacts. That's called B lines. And if you see the irregularity of the pleura, what you will see would be the contour is irregular, sliding is lost, and the deeper the irregularity, greater the pathology. So you will see grades of subpleural consolidation, sonologic term, and as the consolidation deepens, I will show you other pathognomic signs that you will see. And we have always seen effusion. This is any fluid is very friendly with ultrasound. So if you see fluid from time immemorial, this has been a modality where we have used ultrasound. Effusion is best diagnosed by ultrasound. As well, you will see a anaphylactic lung floating in the effusion. This is called as a jellyfish sign. This is by far the best modality. As well, the fluid starts to show you, enhance the deeper structures visibility. This will make, like a normal lung will not let you see the spine beyond it. So you will start seeing the spine. This is called the spine sign of pleural effusion. And of course, pneumothorax, as we know, unstable patients, you can't read it, you have to take immediate decisions. Pneumothorax, best 100% pathognomic signs are available in lung ultrasound to detect pneumothorax. So I'll go over it individually. Irregular pleura, this is most of our pediatric attendants where viral pneumonias will begin with pathology in the pleura, and irregular pleura is what you see. So you can see from their basis vertical artifacts. This is a classic picture of irregular pleura and the lines of viral pneumonias. That is a picture of COVID actually. Then the second picture, a closer look of these irregularity, is a picture called a subpleural consolidation. And again, from their bases, what you see are the vertical artifacts of B lines. And in pneumonia, we'll go a little in detail over this. Pneumonia, the irregularities deepens more than 1 centimeter by some convention in the depth of the consolidation. As well, you can see the white dots in that irregular region. As I said, air is hyperechoic. So these white dots are air bronchogram. We know in conventional radiography, air bronchogram is part of a diagnostic feature in chest X-ray as well. So these air bronchogram are dynamic. They move up and down with respiration. This is indicative of dynamic air bronchogram is an equivalent pathognomic radiologic sign of pneumonia or consolidation. If it is not dynamic, it is suggestive of atelectasis. So this is this constellation of symptoms for pneumonia. You will see air bronchograms, which is dynamic, and something called a Shred sign because of the pleura's irregularity and its receding margins. And constellation of these signs put together can diagnose pneumonia in good measure. Just to break the monotony, what would you think asthma would appear in lung ultrasound? Asthma, we discussed many COPD and asthmas in the previous talks. Asthma is highlighted by hyperinflation or well-aerated lungs or over-aerated lungs. So as we can imagine, we will be seeing pure A lines. And in exacerbations, when it is reaching the pulsal paradoxus scenario, you can see the sliding starts disappearing. So you can grade asthma severity in silent chest, or when you want to compare it with probable bronchiolitis, we know severe distress, bronchiolitis, we are urged not to give bronchodilators. The outcomes are difficult or worse if you give bronchodilators. So if we have a useful way of distinguishing between viral V's, which is pure asthma exacerbation, or bronchiolitis, this would be one of it, where if you see just A lines, you're talking about asthma exacerbation. If you see B lines, subpleural consolidations, and according to severity was picture, we are dealing with bronchiolitis. So the next scenario is effusion. As I said, effusion, hands down, this is the best modality. What would you see? Black. What's black? Fluid. Any effusion will appear anechoic, and you will see floating lung in it. And as I said, what you will see? Deeper structures which cannot be seen in aerated lung. That's called the spine sign. That kind of puts together all the pathology in lung, and the pattern of one and other together can almost get anything in the lung pathologies with lung ultrasound. So what's seen in pleural effusion? The anechoic area bordered by 4 borders. You can imagine what the borders are. And the deeper structure of the spine. This is the classic spine sign of effusion. And if you put the mode called M mode, you can see the floating lung going up and down in a wave. That's called the sign-based sign. So the next, as I said, this picture is a one-page view. You can see the QR codes. You can learn them very easily. A dedicated 2-hour learning, you can pick it all up. So I'll go over a blue protocol, which is the classic coined protocol, which I will detail. It's a validated protocol for emergencies. I'll go over the details of it in the next slide. I want to talk about another pathology which can be picked with 100% specificity. That's the pneumothorax. What is seen here is a portion with no sliding. No sliding, suggestive of pneumothorax already. but it meets as you keep scanning and you meet the area of sliding. This area of no sliding meeting sliding is called as lung point. This is 100% specific for pneumothorax. So pneumothorax, you would want to intervene at the spot, as quickly as possible if it is a tension pneumothorax, and you would not wait for imaging modalities. You are in SU or emergencies, so this would be one of the very good modalities to use. So as I said, a one-page view of all the lung pathologies, constellation of artifacts. That's the beauty of it. You cannot image a lung as lung. Because air is really not good with ultrasound, it scatters, gives you lots of nuisance and artifacts. But these artifacts have been compiled together in patterns, and that's the pattern we saw as the bread and butter of lung ultrasound. So let me go over clinical situations where we'll be using in pediatric emergencies when we want to rapidly differentiate undifferentiated dyspnea. They come with 100 possibilities. So when you put a probe and you elicit these patterns, you can delineate one of the pattern and get to differentiate what it is and proceed with the relevant intervention. So that's the beauty of lung ultrasound position in pediatric emergencies, and there are validated protocols. One such is called a blue protocol. As I said, pneumothorax, pleural effusion, there is no debate. They have been there for time, and they are serving the purpose of an intensivist to diagnose with lung ultrasound. So what's the protocol that I'm talking about? This was coined by a gentleman called David Lichtenstein. He is now popularly known as the father of lung ultrasound. He, by a serendipity, discovered lung ultrasound, and now it's a mature protocol in all ICUs. What is done is the route here is begin with lung sliding. As you can see, if it's absent, start thinking about in an undifferentiated dyspnea. This is what I'm trying to tell. You will see if it's absent, you will be looking at possibility of pneumothorax. As I said, locate lung point, you're 100% there. If it is V profile in consolidation or where the pleura is lung sliding because of its irregularity, if you see dynamic air bronchogram, you are hitting on pneumonia. And if it's A lines with sliding, pure A lines, highly dyspneic, you're looking at asthma or COPD in adults. But if you see the sliding is absent, you are probably seeing a severe asthma.
5 minutes.
Yeah. So what are the other possibilities? As I said, bronchiolitis and asthma, it's a very useful thing to distinguish. And an intensivist, after intubating, would want a way. So amongst the ETCO2 and getting a chest X-ray, this is bedside tool available to confirm the position. If you see double lumen, you're probably in esophagus. If you see a single lumen, you proceed. You see sliding on both sides, you are in right place. Supposing you don't see on this left side, it could be pneumothorax of that side, or you are left bronchial intubation. You have another sign called lung pulse. If you see this pulse, that means there is no pneumothorax. Start withdrawing until the pulse disappears, then you are in position right about the carina. This is a way to check on position of intubation. So in neonatology, as I said, it has very validated evidence available for its utility, best in RDS. In RDS, the intervention everybody knows is surfactant, and when to give surfactant as well. After giving surfactant, what is the resolution can all be studied with ease and specificity, and that's the beauty of using lung ultrasound in neonatology, as well as a golden hour triage. If you want to distinguish between the three common ones, the RDS, DT, and MAS, they have typical patterns. This is one of the, and as I said, pneumothorax and effusion across all ages, this is one of the very good modalities. So serial X-rays are no longer needed if you have lung ultrasound, and in all NICUs, this becomes standard of care. So how is it help? As the aeration worsens or the fluids increase, or as the RDS severity worsens, the score increases depending on A line, B line, and C profile and effusion. And after giving surfactant, you make cumulative score in the zones as I explained, add up the score, and 7 to 10 score in this kind of division would mean you need to give surfactant. And after giving surfactant, you also see the resolution on the immediate next steps. So these, as I said, in various measures, recent publications, validating it and further adding to information in this research and giving objectivity in lung ultrasound, this is guiding certain adult protocols also. So their lung ultrasound in neonatology is one of the beautiful modules and is showing light for the evolution of science in this field. So one more thing, in TTN, the superior lung fields are well aerated, so you will see a classic double lung point, which is a lot different from the lung point which we talked about in pneumothorax. So this is one of the useful signs, and as I'm running through, I'm just posing the QR codes for you for the further interested reading. And in pediatrics and in adults also, and as I discussed with the previous speaker, in pneumonia, this is one of the diagnostic modules, as I said, the C profile. I'm being urged to proceed through. Yeah. So, pneumonia in children or adult, this is one of the diagnostic modalities, and this is one of the well-studied meta-analysis where 12 studies have been pulled together, and it really outperforms chest X-ray, and it is here to stay as a standard of care for diagnosing. And more useful is to distinguish the etiology. You need this for the stewardship. You wouldn't unnecessarily want to start antibiotics for viral pneumonia, so you would want a modality which can help you discern the distinguishing features between bacterioviral and atypical. So focal, deeper, large consolidations will be bacterial, diffuse, multiple will be viral, and the reticulonodular pattern would be atypical. So it is atypical, and we do distinguish it because mycoplasma is one of the pediatric pneumonia suggestions. So in bees and bronchiolitis, to distinguish between the two, as I explained in the previous slide, this is one of the beautiful situations. Many studies have been done in bronchiolitis, and the recent ones are standard of care. You explore the posterior areas, if you find pathology, it is already prognosticating the higher oxygenation need. And that's the beauty of using ultrasound in bronchiolitis as triage, as well as in the ICU. So,
I'm afraid that we have finished the time.
Thank you. So I would want to wind up with the message that lung ultrasound is one of a versatile tool available from triage to the ICUs in different clinical situations, adults, pediatrics, neonatology, and it is useful as a hemodynamic assessment tool as well. So I want to sensitize the audience for its transformative position that it has achieved in various disciplines, and it's a matter of time to learn the patterns, and it's gonna serve a long way purpose in whoever you are as a clinician. It is transforming the way you see medicine if you start using the tool. I just wanted to show one of the tool. It's as small as this.